Thank you for joining us for Conversations in Hematology Oncology. During this segment, we'll be discussing properties of bispecific antibodies and addressing current unmet needs in B-cell non-Hodgkin's lymphoma. I'm Dr. Matthew Lunning, Associate Professor of Hematology Oncology at the University of Nebraska Medical Center in Omaha, Nebraska. I'm joined by my colleagues, Dr. Salles from Memorial Sloan Kettering Cancer Center in New York, and Swetha Kambhampati in Duarte, California at the City of Hope. So thank you everybody for joining today. I think what we first want to talk about is really there's been just a significant explosion in B-cell non-Hodgkin's lymphomas, both on the indolent non-Hodgkin's lymphoma subtype, where we know follicular lymphoma is the most common, as well as our aggressive non-Hodgkin's lymphomas, where we know that diffuse large B-cell lymphoma is most common. Dr. Salles, can you really kind of talk about the POLARx trial and how the POLARx trial has impacted your day-to-day treatment of diffuse large B-cell lymphoma?
Thank you, Dr. Lunning, for this question. Well, as you know, we have been treating patients with diffuse large B-cell lymphoma using rituximab and CHOP for 20 years. So POLARx trial substituted vincristine with polatuzumab vedotin, an antibody-drug conjugate against CD79B, and showed a benefit in terms of progression-free survival, but not in terms of overall survival. I think for those patients that entered the trial and have the same characteristic, I tend to use that. However, we still have about 25 to 30% of the patients that will probably have treatment failure. So there is really still room for improvement for patients with DLBCL.
So Dr. Kambhampati, I think we saw a nice review done kind of following the POLARx trial, looking at those patients that are, at high risk for relapse, and that about 3/4 of the relapses occur within 1 year of completion of their primary therapy. I think in that population, we know we need more effective therapies. Could you maybe comment about kind of how your treatment strategy has changed perhaps over the last 6 to 12 months?
Yeah, thank you, Dr. Lang. That's a great question. I'd say in the last year, with the results from the ZUMA-7 study and in last ASCO demonstrating a second-line CAR-T demonstrating an overall survival benefit, I'd say my practice has really changed that for those patients who relapse within 1 year of initial chemoimmunotherapy, and if they're eligible for CAR-T, I tend to take them for second-line CAR-T based on the results of the ZUMA-7 study. For those patients who are not eligible for CAR-T and for those patients who are relapse late but are not eligible for transplant, I still take them to CAR-T with liso-cel based on the pilot study data. And then for those patients who relapse after 1 year, I tend to do, if they're transplant eligible, salvage chemoimmunotherapy followed by transplant if they achieve a CR to salvage, versus CAR-T if they don't achieve a CR. So that's really, these landmark studies have really changed my practice in the last year.
So Dr. Salles, Dr. Kambhampati talked to us about those 2 landmark trials, but you and I both know as we venture into the commercial environment, part of half the battle is getting to the CAR T cell because of just the aggressiveness in this population. Can you maybe talk through some of the processes of getting to a CAR T cell that go beyond the clinical trials from that standpoint?
Yes, clearly you have defined an expression, which is the time from brain to vein, the time when we decided we need to do CAR-T for this patient until the time the patient is effectively infused with CAR-T. And this time is probably like 5, 6, 7, sometimes 8 weeks. And we do know that some patients with diffuse large B-cell lymphoma clearly can't wait 8 weeks. And then we are juggling with the time of apheresis. Can we apherese this patient tomorrow or next week? Do we have clearance from insurance? Is the patient informed about all the constraints? Do we have to do bridging? What kind of treatment are we using with bridging? We do know that some patients in which the pace of the disease is really aggressive probably can't make it to CAR-T. The second thing is that beside insurance issues, there are constraints for patients. They should be sitting for about 1 month close to the centers, maybe a few days inpatient, the rest outpatient. But not everybody can be traveling several hundred miles, or affording the stay in a city as expensive as the one where I live. And finally, there are clearly toxicities associated with this treatment, including cytokine release syndrome, neurotoxicity, infections, late cytopenia, which may not make suitable for everybody or difficult to manage when the patient comes back to its community. And overall, while this has been a revolution, saving lives of hundreds, thousands of individuals, unfortunately, probably only half of the patient will ultimately benefit from this therapy. So again, some unmet need here.
So Dr. Kambhampati, Dr. Salles alluded to that while it's revolutionary, it isn't curing everybody in that high-risk population or even in two prior treatments and beyond. That kind of brings into, the real-world experiences. We really had no idea what to do with patients relapsing post-CAR T. Now we're starting to see data emerge, especially with our bispecific CD3, CD20 bispecific antibodies. But I think it's creating some confusion because there's a lot of them coming out, whether or not it's commercially available with epcoritamab and glofitamab, but also some other bispecifics in development. Could you maybe walk through how these bispecifics work and if there's any significant differences that you see?
Yeah, so thank you, Dr. Lunning. The bispecifics, as you said, have really, I think, been the new next things after CAR T as an immunotherapy agent that's shown really promising responses, even in the post-CAR T setting, which is a large unmet need at this time. So the bispecific drugs I explain to my patients are basically drugs that have two ends of them, an end that binds to the CD3 on the T cells and the other end that binds to CD20 on the lymphoma cells, and essentially bring the T cells directly to the lymphoma cells. And we have now several bispecifics that are FDA approved. We have glofitamab and epcoritamab approved for relapsed refractory DLBCL, and mosunetuzumab in follicular. And they all differ in their properties, structures, and mechanisms of action, with mosunetuzumab and glofitamab being more fixed duration of treatment, and epcoritamab being indefinite, epcoritamab being sub-Q, mosunetuzumab is mosunetuzumab glofitamab or IV. There is a subcutaneous formulation coming for mosunetuzumab as well, though not FDA approved yet. So I think these are just some of the bispecific. There are more, and there are others that are in trials, but I think it really becomes a discussion with the patient and sort of what's available at your institution and comfort at your institution, but also whether they prefer IV versus subcutaneous, fixed versus indefinite. But the responses, it's hard to compare between studies, but overall seem to be pretty comparable in the trials.
Thank you. And I'm going to give Dr. Salles the hot potato question here. So we have two bispecifics approved in relapsed refractory large B-cell lymphoma. One's fixed duration, one's continuous. Let's say you have a CAR T-cell patient that's relapsing. How are you choosing between the two bispecifics right now?
Well, as alluded by Dr. Kambhampati, basically, it looks like the response rate and complete response rate from these two antibodies are really similar, about 40% of the patient, probably after CAR T more like 30 to 35% of the patient. So I really think that this question of differentiating between fixed versus continuous therapy is not a very important question. What is important is to achieve the complete response. Everything will be decided during the first 6 weeks, 8 weeks. Either the patient achieved a complete response or a very good partial response that will ultimately translate to a CR, either there is unfortunately a treatment failure. So when it comes to the end of the fixed duration therapy, hopefully the CR will be achieved, we will stop. For the antibodies that had a continuous infusion, should we really continue for indefinite time? I'm not convinced personally. So besides the fact that it's approved like that, maybe stopping, after 6 months, 12 months when the patient is in persistent CR will be sufficient. Then there is a discussion and preparation of the patient that in one case, it's clearly fixed, and we have a time where we said you should achieve a response. If you don't achieve a response, we'll change. And when you achieve a response, we'll stop at 8 months. For the other one, it gives a little bit of flexibility. you know, I think experience will tell us at the end of the day how we use those drugs. But again, the goal is achieving a rapid complete response.
Well, there you have it, folks. A rapid complete response is the first step in the treatment with bispecifics in relapsed refractory diffuse large B-cell lymphoma. I could not agree more. Everything beyond that is sweet potatoes. All right, so thank you for joining us in this segment on properties of bispecific antibodies and addressing current unmet needs in B-cell non-Hodgkin's lymphoma. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access supplemental slides, as well as other topic segments and case scenarios.